Good afternoon, everyone. Welcome to Digital Interventions Supporting Healthy Communities and Life Changes. My name is Michelle Hall, and I'm an educational technologist with the Center for New Media Teaching and Learning. I have two people presenting with me today. I have Dr. Helen DePino. She's an assistant professor of clinical population and family health in the Mailman School of Public Health. And I have my colleague from the Center for New Media, Jessica Rowe, who's our senior program specialist for Triangle Initiatives. So since we've been established, we've been committed to partnering with CU faculty on various initiatives to explore the use of digital technologies in the classroom. But over the last 4 years or so, we've extended the scope and reach of our work, and our strategic initiatives in particular focus on how we integrate digital technologies and media in efforts to address some of the world's health and environmental problems. So our Triangle initiative served the intersecting interests of education, research, and the larger community, and our Global Learning Initiative uses the power of network technology to create new opportunities for collaboration. So these problems that we've been addressing are traditionally, they've been mapped out by public health professionals into neat linear pathways with a clear set of determinants of processes and defined outcomes. And we found that based on these linear pathways, the design programs and interventions don't always produce the expected outcomes. And the reason for this failure is often because public health problems, and the projects we're going to describe today all have to do with public health. It's because they're messy and it's not easy to reduce them to simple linear pathways. They're complex problems with numerous interconnections and feedback loops. And there's a great quote by Donald Shawn, who's the author of Educating the Reflective Practitioner. And he said, "In the swampy lowland, messy, confusing problems defy simple, reductionist approaches." So we've now found that this is where the challenge and the opportunity lies for CCNMTL and its partners, that we need tools to help us make better sense of the swamp, to help us model the swamp in order for us to intervene. So I need to advance. I'm having a little bit of problems with the mouse. Martine. Okay, there. Sorry. So while we're still creating tools for the classroom, we're still supporting teaching and learning at Columbia, but we are finding that more and more our faculty are in the swamp, tackling problems in the world and engaged in research that reach beyond the scope of, reach beyond the boundaries of classrooms. So very recently, our projects we've been creating projects that focus on creating awareness of local and global issues, public health, as well as other social issues. We're supporting Columbia faculty in their research activities, and we're working to help these instructors bring the products of their research, the faculty-developed interventions, directly to the affected communities in the US and globally. So this afternoon, we are going to take you on a tour of 3 projects that were designed to support one or more of those things I just mentioned. So the 3 projects are Lanratam, Massive Zucchini, and My Smile Buddy. They were developed together with our faculty, all of them from the School of Public Health here at Columbia, and one person has a joint appointment in the College of Dental Medicine. And with these projects, we are using technology to model complex phenomena. They allow us to to have our learners experiment in a safe environment. We're reaching a population that's larger than just the students in the classroom. And with the last two, massive leukemia, my Smile Buddy, they're actually being used to directly deliver interventions. So Helen and I will start off and talk about Lanretam, and then we'll turn it over to Jessica to walk us through massive leukemia and my Smile Buddy. So, a little bit about Lanretam in the beginning. So, we started working on this project in the summer of 2009 with the Averting Maternal Death and Disability program in the School of Public Health. And it was when they were preparing for an African Regional Conference on Human Resources. This conference, they were expecting about 300 plus people from around Africa, mostly human resource personnel and clinicians. And the goals of the conference were to examine and share innovations, innovative ways in which non-physician clinicians have been utilized to reduce maternal mortality and newborn deaths in Africa, and also to explore strategies for drawing on transferring those lessons learned. And so AMDD wanted to create some educational sessions that after 2 days of presentations, it would give the participants an opportunity to critically assess a health system and actually do an analysis of how MPCs are being used for, okay, so there were we wanted them to be able to solve problems in teams. So we could have easily used any of the experiences that from the African countries there. There were many countries present who were actually using MPCs, but we were really concerned that people would not be free to fully analyze these issues if they were dealing with countries that they were familiar with. So we decided to develop a case. And so we were really encouraged by the promise of case-based teaching to help learners develop skills in analytical thinking and reflective judgment. And cases are generally made up of 3 parts, and this one was no different. We had a core team of about 6 people who helped us work together to create a real-world scenario. There were many supporting documents and the open-ended problems. And I have to say, we did this in about 4 weeks. So the Republic of Lanretam, a fictional developing country in Africa, was born. And this case study focuses on the problem of how to reduce maternal mortality by ensuring the implementation of emergency obstetric services. So in the story of Lanretam, Lanretam has piloted a new cadre of health workers, non-physician clinicians, and is faced with managing a national scale-up program. So the learners, and in this case, the very first time we ran it, the learners were the participants at the conference. They played the role of experts who come in to assess the health system and to review the midterm results of this pilot program. And to eventually advise the government on strategies to create an enabling environment. And the students, the learners, the participants, they were asked to consider 5 different factors, and actually there were 5 parallel sessions, very much like what we're doing today. And so they got opportunity to either go to human resources management, human resource policy and planning, referral, infrastructure, commodities, and quality of care. So we created the entire narrative as well as the facilitators' notes, the session presentations, and the worksheets that went along with the questions. So since then, this case study was used again in a training course, I think earlier this year in Ifakara, Tanzania. And this time it was mainly a course with care providers. And then this spring in April, Helen used it in her systems thinking approach to maternal health. And so I'll ask Helen to come and tell you a little bit about what the work that she does in AMDD, and then much more in depth in how she has used the Lanretam case study in her course.
So, thank you very much, and thanks for being here. So a little bit of background as to where this all fits in with the work that we're doing. AMDD, which is the Averting Maternal Death and Disability Program at the School of Public Health, is a global program that is really looking at the sort of research capacity building and real sort of engagement with ministries of health in. We've worked in over 59 different countries, mainly in sub-Saharan Africa and Asia, focused on reducing maternal mortality. And this has been going on since 1999. And why do we do this? Well, just some background. Every year, there are 350,000 women who die as a result of unsafe, inadequate emergency obstetric care and as a result of pregnancy-related complications. In addition to this, there are another 3 million deaths of early neonatal deaths directly related to poor obstetric care, and an additional 4 million fresh, what we call fresh stillbirths, in other words, stillbirths that occur where the woman has entered into the labor ward where the fetal heart is heard and it dies as a result of poor obstetric care. In other words, we're looking at millions of deaths every year, and the very sad reality is that 99% of these deaths are happening in the developing world. So we know that there are these interventions to reduce maternal mortality. It's not rocket science. They're known, and if implemented correctly, could decrease these numbers by 74%. And we could meet MDG 5, and we're way off that target at the moment. So where AMDD fits in is that we've been working in partnerships with UN agencies, non-governmental organizations, to expand the availability and the quality and access to emergency obstetric care. So what has this got to do with Lanretam? Well, what it's got to do with it is that over the years, what we've learned is that this is a complex problem. It's messy and it's complex. If it was simple, women wouldn't be dying. And so what we've seen is that we really believe that sustained and significant reductions in maternal mortality rates are only going to be achieved through systemic countrywide improvements. And the minute you're talking about these kinds of scale, you're talking about complex problems. You're talking about an interlinked complex problem. So as we've been thinking about this, and just as here's one example of a problem, and I know some people have seen the slide before, but this is how women are transported in Ayacucho in Peru, where people have take turns in carrying the stretcher across the mountain. And actually the system works, but it's part of a system. So what we were trying to do in the course that I developed with incredible support from Michelle and CC and MTL was really to say, how do we develop a course that will teach our students to think in a systems way? And so the course, in 7 weeks, students were expected to have an understanding of maternal mortality and the key factors to reduce maternal mortality. To understand what we're talking about when we're talking about complex adaptive systems and health systems, and then to have some tools to engage in how they make sense of this very swampy, messy situation. How do they put some of this all together, and what are the tools that we can use? And one of the tools that we used was to take all the learning that we had gathered in Lanretam. And how many of you worked out the Lanretam name?
I started out looking for it on that map of Africa. And then I went, oh, let's try reading it back.
Let's try reading it backwards. Yes. Okay. So Lanretam. Okay, so let me take you through Lanretam, maternal backwards. And what, as Michelle said, what we created in Lanretam was a country, and let me tell you that I've worked with, when we ran this course in Tanzania, I had some of the providers wanting jobs in Lanretam, asking me if there was any jobs going. So I think we did a really good job in making this realistic. So here we have the website. So what students were faced with, so as part of this course, students were introduced to Lanretam, and prior to being introduced to Lanretam, I had provided them with some tools to think about how to develop systems maps. And for those of you who are familiar with this, we used Vensim as the program to engage in some of this mapping, and I will show you the outputs of that. And we exposed them to Lanretam, and we built up Lanretam, and this is a big we. This is me and CCNMTL and a team of us from AMDD. And there's a lot of information about this country, and we decided to present this as a developing country's Ministry of Health's website. So what you see is as if you're landing on the website for the Ministry of Health in Lanretam. And we looked at various websites, and we think we've got one of the better ones going in sub-Saharan Africa. We developed maps, and we tried to make them as accurate as possible. If any of you have any sense of geography, flip it over. It's actually the Great Rift Valley. We added on this map additional information that people may need. So if they wanted to know what the population density was like in these 5 provinces, we were able to map in the hospitals and the health centers what the electric and cell phone coverage would be like, the referral zone. So we gave people a lot of information. We had information on the health statistics. What were the human resources, and what is the general demographic statistics like? We had organograms so that people knew what the executive management looked like, what the various clinical services were available, human resource planning, admin. It really was extensive. Public health and environmental. We gave them some links to external websites that they could be useful, thought would be useful. Their various programs. Clearly, the guinea worm people are not as up to date as we were in maternal health services. And then within the maternal health services, we provided a lot of information on the policies, on the statistics. And in a way, we purposefully made this pretty overwhelming, because when students go out there, and a lot of our students in public health will go out there and be faced with just this barrage of information, and how do they distill this, and how do they extract from that things that would be helpful. So we tasked the, just to go back to some of the different, we then tasked, as we had done in the Ethiopia conference, we tasked the students to act as consultants to help Lanretam solve a particular problem, which was scaling up a program for which they had results of a midterm assessment. And in particular, it was a way of dealing with a whole bunch of information, because I only had a 7-week course, and I wanted them to also learn about issues of referral and how that impacts on maternal mortality, on issues on quality of care, human resource policies, and commodities and supplies. And so the Minister of Health, who's this wonderful woman in Lanretam, had tasked these consultants with particular request to provide solutions to problems. So how we ran this is that students were divided up. The class was 24 students big. I didn't want to take it any bigger. And they were divided up into expert consultant groups with 4 students per group. And for the first week, they looked at Lanretam. They explored it. They tried to get a grasp of what was in Lanretam. So they had access to the website. The following week, they were broken up into task forces, and each person in the group went to a separate task force. One looked at issues of referral, one looked at issues of commodity supply, quality care, and human resource management. And they were given a worksheet to go through to say what are the critical issues in Lanretam. So they had an opportunity to go in depth in a particular area. The following week, they came back to their expert consultant groups. And there they are, and they were smiling. We had one man, so I had to make sure he was in the photo. Colin, he's a stalwart in our department, and they then had to come and try and solve and provide recommendations. We also had a wiki going, and they were posting things on the wiki, and there was a pretty active wiki with a fair amount of interaction and questions and hair tearing and how do we think about this problem. And as a result of that, they were asked to then produce causal loop diagrams. And I know these look like spaghetti, but actually they make sense. If you are the person who's created them, and what you've been trying to do is say, how in the swampy mess do these things interrelate? Rather than having some linear diagram, here are the interrelationships. So this was from Lanretam looking at how to reduce maternal mortality. And when we start to look at that, we can also say, well, there's clearly some core key leverage points where there were lots of arrows coming in and out that made sense as a starting point. So students were provided with these skills. How much depth can you go into in 7 weeks? Not a lot, but they had a feel for it. And I know that this has had an impact on the work because students have gone on to use these systems thinking tools in different ways. And so since the course, I've got 2 students doing their capstones with me specifically because they want to use a systems approach, and a 3rd student who's quite remarkable, who went to northern Uganda for her practicum and was asked to look at maternal mortality and why women were not utilizing services. And she thought the only way she can make sense of all the data she was getting is to map it out, and was able to use this map as a discussion point for the IRA, the International Rescue Committee with whom she was working, and have them reflect on that. So just to say that the feedback was great. Students were extremely excited. They were extremely overworked. The sort of biggest negative feedback was, why is this only a 7-week course? And it's mainly for my own sanity. But they really did learn skills, and they loved Lanretam. Lanretam provided them with kind of a real feel for what was going on without getting too caught up in the other parts of the country. But it did give them that messy feel. So let me finish there.
Thank you, Helen. So yes, we had some really great feedback from the students, but also from other instructors in the department. And there's some ideas for what we could probably do next with Lanretam. So one idea is to keep the core narrative of Lanretam, but maybe use it in a human rights course where the scenario is now that Lanretam will sign or not sign some treaties or make formal reservations with Amnesty International, something like that, and then students would have to analyze data and come up with recommendations for how to deal with rights violations and that type of thing. And then also in the department, another idea was to use it in the reproductive health in crisis situations course. And we can have a crisis on the border of Lanretam, and all of a sudden there are thousands and thousands of women and children, and men, of course, as well, you know, flooding into the rural provinces. And then how do you deal with now a need for more maternal health services? And we're also, there was a part of the feedback we got from the conference that started this entire project was that the AMDD's partners in African countries, as well as their UN partners, are really very interested in using Lanretam as a teaching tool in their own training programs. And so we're also beginning to think about how to disseminate the content. We used it as a paper-based case at the conference in Ifakara, mainly because we didn't have the website as yet. But we do have to think about how we disseminate for people to use in places where they may not have an active internet connection. And as recently as 2 days ago, Helen and I have started to put our heads together to think about what Lanretam 2.0 will be. And it's becoming really important to think about how we can model other health systems. Not all all health systems that need to be analyzed have the same profile as Lanretam. So if you were thinking about South Asia, it might look very different. So how we can have some kind of dynamic way to tweak the data in the back end. And what Helen did not tell you was all those charts and all those graphs that you saw are made from, they're all internally consistent, and she did a heroic job with these spreadsheets. So you can go on any part of that Lanretam website and come up with a number of doctors in the province, and it ties back to the data on some other page. And so since we have that already in place, how can we find some dynamic way to make it relevant to a different country profile? So that's all we have for Lanretam. And so I'll ask Jessica to come and walk us through these other two projects, and she'll start with Massavucini.
Okay, hi. So this first project that I'm going to show you was developed to help HIV-positive patients in South Africa remain adherent to their treatment regimens. And we did this project in partnership with Dr. Robert Remian, who is actually here. Hello. From the HIV Center. HIV-positive patients remaining adherent to their treatment regimens is actually it's a difficult problem, because while antiretroviral treatment holds promise to really extend lives and the quality of life for people with HIV, it also requires really exact adherence to a regimen of pills twice a day, every day, for the rest of a patient's life. And humans are fallible and inexact, and there are lots of pressures on a person that might cause him or her not to adhere to any given regimen. So this project was developed for South Africa, and right now in South Africa, a system is in place that provides counseling to patients before that patient starts antiretroviral treatment. The system right now is that the patient selects what is called a treatment buddy, which is one person who knows that the patient's HIV status and is willing to go to 3 counseling sessions with the patient. The patient and their buddy go through these 3 sessions, and then the patient begins treatment. But if the patient later has trouble maintaining their regimen, there's no system in place to sort of help beyond sending the patient back to a counselor. But there's no kind of strategy for what's supposed to happen next. So Massavucini is an attempt at filling that treatment gap. It's a behavioral intervention, and a behavioral intervention is one way to help people maintain adherence. For this project, we worked with the HIV Center to adapt an intervention that was originally developed for a US population and changed it for the South African context. We used community-based participatory research methods, and we collaborated with the University of Cape Town and also staff at a treatment clinic outside of Cape Town to develop activities that teach health concepts and problem-solving techniques and increase patient motivation. We went to South Africa with people from the HIV Center, and then we had meetings with the clinic that we were working with for maybe a year afterwards to collaboratively design and develop what we eventually made. The project began as a small feasibility pilot study, which is just coming to a close right now. So 66 patients went through the study, and we have some preliminary data. So now I'm going to show you what we made. The materials we developed support counselors as they deliver this intervention. So the purpose is to help them deliver effective and consistent adherence messages. They work with a laptop. The project gave a laptop to the clinic, and the laptop acts as a guide through the 6 sessions. And the context for this is that the counselor is in a room with a computer with the patient and their treatment partner. So this is what the counselor would see when they first logged in their patient. You're looking at essentially a table of contents. These are the 6 sessions. So you follow the green box, essentially, that says what you're supposed to do next. So here is the index for the 1 session. And if you look at one of these sessions, you'll see that the counselor is given an objective and a procedure and a sample script if they need a script to follow to kind of keep on track. They can know how long it's going to take, and when they complete the activity, it marks off and it shows them that they've done this. So there are also several interactive activities that the patient and the counselor and the treatment buddy all would do together. So I'll show you 2 of those. This activity was developed to help patients understand the relationship between CD4 count, viral load, and opportunistic infection. And we developed the concept in collaboration with the clinic. Nurses, volunteers, counselors, and the psychologists there helped us come up with the island metaphor, the idea of rising water to kind of talk about getting closer and closer to danger. So the patient can manipulate these sliders and see that if their opportunistic infection, they get one, and their viral load is up, and then their CD4 count starts to drop, they're getting closer and closer to being underwater. Something else you might notice, depending on how close you are to the screen, is that the body on the island is actually getting thinner as it lowers. And the reason that we did that is because the nurses at the clinic had told us that the best way that they had found to talk with patients about the stages of the disease was to use what they had this big poster that showed the body getting thinner and thinner as the disease progressed. So we tried to incorporate that into this activity. The island figure is a man or a woman, depending on the sex of the patient who is logged in. The second half of this activity talks about adherence, and it shows how maintaining adherence or not affects those other 3 factors. So we've actually gotten very good feedback about this activity. Patients and counselors have both told us that it really helped them understand what was going on with their health. So we're very pleased with that. I'll show you one other activity, which is the activity about the treatment regimen itself. And so in South Africa, the pills that are provided are coming from generic companies, and they might come from different companies depending from month to month. So the pills may look different, and may actually, each individual pill may be a different dosage from what you're used to from the previous month. So this activity is to try to help people talk with the counselor and the buddy about what is the regimen, do they really have it correct, and to sort of try to overcome some issues that might be there for problems with literacy, reading English, if your pills bottles are marked in English, that you actually know what you're supposed to be doing. So this activity, first the patient chooses, are they on line 1 or line 2 medications? And then they have this big list. These are all the pills that they could possibly have been given if they were on this line from the different companies. So they can choose them by what they look like or by name. So I'm selecting a few pills here, although I have to say I don't know what a regimen actually would look like. And then they can put these pills in their morning and evening kind of pill buckets. So you can say I take 2 of these in the morning and 1 of these, and in the evening I take this. And then here we have a check, are you really taking them 12 hours apart? Or not. So, they select when they take them, and then they can have a conversation about that. This is really to try to start the conversation with the counselor, to make sure that everybody's on the same page. And then they can change this. So if this isn't right, you can drag pills out, they'll disappear, put different ones in. And then you can get a printout of this at the end. So if you want a visual reminder of what your regimen is, you can take it home with you. There are several other activities, but I'm going to stick with these 2 for now. The pilot results that we just have read the initial report that Dr. Remy and his team wrote, and it looks like the feasibility study has had really great results. There's a very high level of interest at the clinic to keep using the intervention. They want to use it with everyone and incorporate it into their standard of care. I really think that's because they helped us design it, so they feel a sense of ownership about it. It's really something that they made. The patients, counselors, and staff all report that it's engaging and useful, and there are reports of feelings of self-efficacy and self-reports of adherence that show that it may be effective, although we don't have statistically relevant data right now because it was a very small feasibility study. So this was funded by the NIMH, and our next step is to do a larger test of efficacy. So we're going to be submitting that grant in January. So I hope we get to continue on this project. All right, I'm going to switch now to showing you a project about childhood tooth decay. This project is called My Smile Buddy. That very cute tooth there you see is the Smile Buddy. And this project is very new. It's in development right now. Our partner on this is Dr. Burton Edelstein from the dental school, and he has also an appointment at the School of Public Health. So this childhood tooth decay is a chronic health issue that actually can affect you throughout your life. It's called early childhood caries, and like HIV treatment non-adherence, it also has multiple complicated causes from genetic to dietary, and it can have pretty severe effects. If you get really severe tooth decay as a child, it will continue. It's not just in the baby teeth, it stays in your mouth for the rest of your life. So this tool is to try to help community health workers assess a child's risk for early childhood caries, and then to counsel that child's family in making changes to help the kid's oral health. With enough behavior change, early childhood caries is actually completely preventable. But by the time most people see a dentist, the issue is not prevention, but it's repair at that point. Dr. Edelstein is trying to, with this project, he's thinking about trying to move preventative care into the hands of health workers who actually see children earlier and more frequently. So community health workers, pediatricians, people who see children much more frequently than dentists. The target of this intervention right now, at least for this pilot study, is minority and low-income families. Low-income and minority children are actually twice as likely to have caries and have half the access to dental care. This project is developed using tablet computers, in this case iPads. So you're going to see as I show you the tool that some of the design choices we made are because it's for a touch screen. So think about having to move things around with your finger. It's being developed for a population in Morningside Heights. We've been working with community health workers and parents in the community to develop materials that are appropriate for that population. And so, as I said, this is in development, so I'm going to be showing you some designs and then some actually working parts. As an opener, the tool will start with a story that's kid-friendly about how caries works. So here we have this tooth, and the voiceover says, your mouth is like a house for your teeth. But if you have caries, your mouth is on fire and your tooth looks really worried. These are what the flames are. But fluoride and diet change can douse these flames. So we have our fire hydrant to the rescue here. And your teeth can live happily ever after. So kudos to Mark Raymond, who designed this. This is a draft of the story, which is actually a little more elaborate at this point. Okay, so I'm going to now switch back to showing you the actual tool. So this, so imagine this being delivered on a tablet computer about this big. And this is something that'll start with an introduction that's a video that incorporates the story you just saw and a mother talking about why taking care of your kid's teeth is important. And then there's an assessment that covers these various areas: diet, feeding practices, clinical history, and fluoride. Capacity up there is going to get changed to thoughts and feelings, because capacity is a pretty clinical kind of public health term. The questions are like this, who brushes your child's teeth? You can select, who brushes the kid's teeth. Like Masibu Kenny, it has a guide for the facilitator if they need it. There's an objective, a really short script. Why are you asking this question? And as you go along, families can learn, so we don't want people to feel like they're just taking a test and they're going to be judged at the end of it. So, for instance, accompanying this question, if they want to learn about toothbrushing, we have things like this video, which, okay, yeah. So this is, again, a draft. We had very obliging 3-year-olds for this. So this video covers, trying to help parents understand if your kids fight with you, you should still brush their teeth. They get older, they still need help. So I won't play this whole thing, but it also goes through techniques for brushing the kids' teeth, different positions that you can use to hold them while you're brushing their teeth. All right. And then the final thing I'm going to show you that we built is the diet assessment. It's very important. This is a big part of whether you're going to have early childhood caries, is what you're eating and how often you're eating it. So this activity is an attempt to help health workers take parents through a 24-hour recall of everything that the kid ate the day before. So we focus grouped these foods with parents in Morningside Heights to make sure that the categories made sense, that they were foods that they actually are feeding their kids. Now you can see that they're not every food in the world. You have to kind of think about what grouping the food falls into, because otherwise this would be like this giant index of all foods and it would be hard to use. But you can say, we ate this at this time and this at this time, and then you can see what you put. You can say whether it was a meal or a snack. You can move it if you got it at the wrong time of day. And you can go back to looking at the pictures, which we're hoping will be a kind of a reminder for, these are some things you might have eaten. Did you eat any of these things the day before? And we have drinks down here as well. So on the back end, the tool is calculating, how risky it was, the foods that were consumed and how closely they were consumed. So this activity is really, I think, the core of the project. When they get done with all of this stuff, and they've done most of or all of the assessment, they then go to their, they get a risk score. So I showed you the tooth story at the beginning so that this little frightened tooth and fire would make sense here. And they have a chance to look at the things that they have an issue with. So the people here, brushing and fluoride was good, but maybe some of the teething methods and sugar consumption were not good. So you can choose what you're going to work on, learn about specific goals that you can work on, and then move to filling out some specific forms about what you're going to try to fix in the coming weeks. So this is going to be piloted probably starting in January. A large group of faculty across Columbia have actually been involved with this. So right now it's also being used in nutrition classes at TC, helping students understand how to develop a risk assessment for a particular issue. This is also funded by the NIH. And again, it's a development grant, so part of this is Dr. Edelstein is collecting data from dental patients to validate the assessment that's running behind this, and then we're going to be doing some qualitative assessments to see how easy it is for people to actually use the tool. So I'm going to turn this back over to Michelle now.
Thank you, Jess. So as you can imagine, the working on these projects have been extremely rewarding for everyone involved. We got really great feedback from the participants in the field, from the students, and I think I can speak for CCNMTL staff when I say that it's been extremely rewarding for us as well. These types of projects bring us more opportunities to work with faculty. Like I mentioned in the beginning, we're not just helping you with your classroom work, but now we're getting into areas of your research and working with your partners outside of Columbia. And so the scope of our work is growing. We've been also able to secure funding. I think it's important to mention that. These projects are big, and this initiative, we're putting a lot of time into it. And we've been able to secure fundings from agencies like the NIH, MIMH, the MacArthur Foundation for some of our global learning work, and we've had funding from CDC for some of our work in the science and other science fields. So from our own internal, educational and technical professionals, this has been totally awesome. We have programmers who are getting an opportunity to create child-friendly interfaces for a touchscreen device, and an opportunity to create culturally relevant activities for patients in South Africa. So all around, it's been extremely rewarding. We've been growing up so we've been growing professionally as well. And I would have to say that finally, the ultimate reward is the promise of being able to do some good in the world. That might sound a little grand and philosophical, but that's how I feel when I work with Helen. And I'm sure that's how Jess feels when she works with Bob and some of these other people. And so, so we want to say thank you for people like Bob and people like Helen for coming to us and giving us the opportunity to do this type of work. And we hope that we've inspired some of you today to think about what is possible in your classrooms and with your partners and with your research and that you may be doing. And thank you for listening to us talk today. For the next 10 or 15 minutes, we'll give you an opportunity to ask questions of us, of any of this work or things that you may have been thinking about. And at this juncture, I also want to just remind you to fill out the evaluation form, hand it in as you're leaving. But in the audience, we have Ryan Kelsey, is our Associate Director for Education, who helps us manage lots of these projects. So I'm sure he'll help us answer any questions. There's Ryan in the back. And Bob, I know I'm putting you on the spot, but if anyone wants to ask about his experience with Masavukeni, thank you, Bob. He's here as well.
And we're going to thank our programmers.
Yes, okay, I will. And before we go to the questions, I just want to make sure I put the slide in and I'm moving on. We can't do any of this. Jess and I can't do these things on our own. All right? We can work with the faculty to talk about, I'll make all these grand ideas, but we have a team of web designers and programmers and video people who really make it possible. So we had a small team for LANRTAM, even though it was lots of work. We had a much bigger team for the other two projects. So I just wanted to say thank you. Hey, Gerard's name is up there. He's in the back. Thanks, Gerard. And so thank you very much for coming today. Thank you.